So I am here as a moderator and as a student. It's really an opportunity for us to ask Karis some deeper dive questions in those 3 areas that Lisa laid out. I hope you guys noted those areas. Happy to have folks chime in, lay out some questions in chat, or unmute yourself and ask the question. The first area we wanted to start in, and because I know we're running a little bit behind schedule really quickly, is around building. And I think this is, basically step 1, and whether you're the facilitator of the network or an MCO or a health system or a CBO, it is really, really critical to create that engaged, high-performing network of organizations. So Karis, I think the first step would be, how do you even get, the criteria and the vetting going on who to include, what stakeholders to include in a network, and what are the various roles that institutions can play in this type of engagement, and using 211 as the example. What I liked about your presentation, it laid out some of the organic evolution that you went through, but I think thinking about the criteria and the starting point of engagement, as well as some of those market dynamics and power dynamics that are there before you even get started, how to account for all of those in doing the network development piece.
Yeah, no, that's a complicated, as you guys know, this has been an organic process for us, and I don't think we've fully figured it out. I actually really appreciated, Karen, your diagram that you showed. I took a screenshot of that because I was like, that's a very nice way to summarize a lot of different concepts in a nice way. And again, the community voice and the power dynamics. I think the most challenging part of this is power dynamics from a community-based organization perspective, because you're trying to incorporate community-based I think that there's an assumption, and I love healthcare providers, they need to be included, but I think there's an assumption that you can solve social needs by buying a technology in some ways, and that like a technology is going to solve for this, but it's really about, and so that's where I think our infrastructure has evolved. Even like I was saying, our toolkit, our manifesto originally like maybe got lost in translation somewhere, is like, I think some people just go to the core components like, okay, we can solve for these, and these are the things we can control. But you're like, okay, well, what are you building for? What's your value proposition? What is your business reason? And then how does that then tie into yours? Okay, well, if you're really solving social needs, the people that are most affected need to be in your conversations, right? And then that requires time and resources and shifting in who actually gets to make decisions, who's traditionally made decisions before. And so even in our own community, and we've been at this for, I keep saying 10 years, I think it's been 10 years. I wasn't around when we first started, but it's been about 10 years. It's hard. It's so hard. Like, even locally, sometimes I'm like, we have health plans that are from the state, and we're a local organization, and they want us to adopt something that's not local. So I don't know if that's, but it is about, so what's unique about our model is that we've created this infrastructure that is a community governance. And I think we started with people that were in it from our operations, like some of our hospital associations, or we have like a health center association, and then some of our CBOs that were players in kind of more collective impact efforts. So that whether that be a United Way, or like now our ACH, we have Accountable Community for Health, or people that are kind of doing coordination, like our regional task force on the homeless, the ones that are kind of facilitating some of those more shared grants or funding that are connected to a lot of partners. So that's how our original governance structure started, was those key stakeholders that could kind of see things from a higher level. Because I think what's also complicated about this is it's really about the person, but it's about changing the system. So, and I think historically we've really focused on agency to agency. And so that's part of our transformation, is now how do we think about, how do we include community voice into that? And how do we have a community advisory board that's weighing in and really advising? Our network partners is another meeting we have. So we have an advisory board, and then we have monthly network partner meetings. And then we have a whole bunch of work groups that focus on a whole bunch of different areas around utilization and adoption, and really instead of the advisory board making decisions top down, we're trying to create it where the community advisory board and our network partners that are using the system and doing direct connection are advising up. So kind of flipping that matrix, and that is not how we started. And it's how we're moving to, and having intention around what that means now. But if we were to restart it again, I would start it the way we're thinking about it now instead of starting it from, I think there's like a strategic lens to it too. And then there's like an operational, like a strategic, like how do you get funding and financing? And then how do you think about it from like actual like person-centered care? And so like, I think we're kind of strategizing, how do we make those two parts meaningful? Sorry, I ramble. Does that make sense to people, or how does that resonate?
It resonates with me. One follow-up question, and then if I don't know if folks are chatting any questions, but one follow-up question I have, you mentioned task forces and kind of some existing infrastructure that might touch those partner organizations or even those populations already. And they may even have funding tied with them. But what's the role of government agencies? Lisa had touched on this in her opening remarks too, and Karen had that incorporated into her theory of change. In your experience, where have the government, the local, the state, where have those kind of played a meaningful role, or how have you had to navigate those types of institutions as well?
We're super lucky in San Diego, so we have a really strong, the way California works is like county based. I'm not sure how it works in New York, but it's very county infrastructure. So the state gives funding to local county organizations to make decisions. So it makes it a lot more complicated, but and convoluted, but also when you have good relationships with our county government, which we do, which is a county that subcontracts a ton of their work to community-based organizations. We have a strong partnership. Our county partner, they actually have an information sharing platform that they have coordinated. They have like 14 different county department programs, and they've created a shared database for their county, and we connect into there. So we integrate with it. And instead of them working with all the CBOs to get on their platform, they've integrated with our platform so that we don't have to have a HIE, a county system, and a CIE. Essentially, the hope is that if you're working with community-based organizations, we can leverage our platform through an integration to be able to do that. So we've, so the county absolutely is a strong partner and have supported this. And we've been able to kind of, through our infrastructure and our neutral state, and I think our trusted relationships, allowed them to leverage it instead of rebuilding, which I think is a challenge currently with the way this is going, is everyone's just building their own thing, and it's, what's the point, right? And then we also include cities. So we have a bunch of different jurisdictions. What's even more complicated is that not only do we have a county, but there's a bunch of cities outside of our county. So we have so we also include cities, which has been an interesting, I'm kind of exploring that now, but it's like fire departments and police departments. And then some of them have housing service programs. So we're figuring out how to leverage it. And I think my hope is to kind of think about this new, defund the police kind of effort around, like, could there be a way that CIE could be leveraged as a way to de-escalate some of those, like being able to do referrals through the CIE for some of those needs that are not, we did some programs with EMS before where they've done direct referrals to 211 instead, for people like for older adults that keep falling, or for behavioral health, substance abuse issues. And so looking at leveraging the CIE platform for some of those efforts too. So we are in collaboration with our cities and our county in a strong way. And I think trying to be that, trying to leverage the infrastructure to not have to recreate the wheels. Where can we, and I think that's part of, the goal of this is like, hey, this is here, how do you leverage it, instead of thinking every new initiative has to come up with a new innovative idea. Can there be an infrastructure and a starting place for anything?
Christina, I'll get to your question in a minute, because I think it's a good transition question to the second area around approaches for outreach and engagement. But was there any other questions around kind of the network development? And I know we touched a little bit on infrastructure, but were there any other questions from this group around some of that engaged network development? No? I'm seeing heads shake. So great responses, Karis, where I think Christine's question leads us into the next piece, which is like, how are you she wants to learn more about the SDOH assessment and risk rating approach. How is that standardized, I think, across, and really, how do you then use that for service coordination and outreach? I think in the New York context with PHS, we're really thinking there are multiple really high performing platforms that the city is using. They each have their own assessment. Then there's the CMS assessment. So how did you create some standardization around this in the effort to inform outreach and service coordination? Christine, did I get that right?
Yeah, that's right. And then of course, if the data is standardized, you have a much easier way to evaluate around the outcomes.
Yep.
And ultimately impact, which is where we all need to be, not just because we want to know that it works, but because we want to get paid for doing the work. So yeah, thank you.
Yeah, I'm sorry, I forgot to, so the risk rating, we call it now the comprehensive social continuum assessment, the CASCA, because we thought risk was a little too assumptive, or kind of like social determinants of health. So we changed the language, and I might have not changed it in that slide, but I think someone from Health Leads, is it you, Denise, is on here? So we've co-published a paper about the CASCA tool. But so no, it's not being used by all 1,200 organizations. It was really established because a lot of tools are binary. So it's like, I'm homeless or I'm not homeless, or I'm food insecure and I'm not in food insecure. And we were trying to create, it really wasn't an intention of getting, well, actually it was, it came out of this where we were contracting with healthcare to do discharge planning for 2-in-1. And basically all they cared about was cost savings. They're like, well, we just want to show there's a reduction in length of stay and that people aren't getting readmitted. And I'm like, well, that's a very short-sighted concept to think about. Like, can we actually measure well-being? And so we actually were using it to be able to measure, because you can't, the idea to get someone homeless to housed is totally ridiculous in California, where there's no housing available. So we were thinking about a continuum to help identify and create constructs so that people stop thinking about things as so binary and yes, no, and think about things as there's a continuum to changing this. And this is to your point, Christine, the system doesn't allow us to not document and track data, because in order to get paid, this is the way the infrastructure has to work. And so I think that's why I think that pathways model is interesting, but it maybe doesn't get to the root. So the idea is to make it, how do we make this person-centered and think about the person's immediacy? And so we have constructs across all 14 domains. So it's about how immediate their situation is, what barriers and supports, so how do you need housing tonight, or are you about to be evicted, or are you living in a home that needs remodeling? You can't live in it. There's mold in your home. Where are you on how immediate your needs are? Is it barriers and supports? What makes it hard for you to get housing? So if you're on parole, if you have bad credit history, if all those kind of things affect your housing situation, and those things may not affect your food situation, right? Maybe in some cases, but not necessarily always. Or do you have someone you can sleep on a couch? Is there some diversion questions we can ask you to figure out, do you have some cash on hand? Can you access those things? And then the third is knowledge and utilization. Where have you accessed resources before? What do you know it's available? So those are constructs that we use to be able to measure that. And that was really a way to, these are concepts. So I never think about we're using the same tools. Everyone's asking similar kind of questions. Can it map to a same data points at the end? So what we're finding is everyone's asking it a different way, and we're not going to ask everyone there's CBOs have been doing this forever. They know this is the way that they do things, or they have contracts that they have to ask these questions for these contracts. So our expectation isn't to adopt our framework. It's could these data points map into this framework? And what we're finding is that there's some consistent data points that map across any way you ask it. It's going to result in some same concepts, especially in some of the more traditional ones like housing and food, and then we're exploring it in some of the other areas. But I think that the intention was to be able to show some sort of change over time and be able to start thinking about a person more holistically instead of so binary. And so I don't know if that fully answers your question, but we're still figuring this out. When we originally built this, we brought everybody together and we were like, what tools, what intake do you have? What intake? And we took everyone's intake and we were like, all right, well, here's some resemblance of what we could put together. And then it changes, and it's changing every year. We change these, we're on version 3 of these assessments. And so I think that also part of this process is like you have to be super agile. You have to change, you have to innovate. It's like, let's just meet wherever people are at kind of thing. And so that's kind of how our tool has evolved too, is like we have new questions or screening tools or information that evolves as the needs change. I don't know if that answered all of your questions, Christine, but I think it was meant more for like a way to start looking at people's well-being changing over time.
Yeah, that answers it. And I think the mapping is fascinating, and the country could learn from that if you find a successful way to do it.
I love the continuum of change versus the binary. I struggle with that, especially with payer clients who really want the outcomes so quantified. But I think there is a willingness to learn from CBOs that hasn't been there before. People are listening to each other in a more active way. So getting this type of successful, I think, strategic coordination out is really powerful. I think going back to some of the operational questions around outreach, what would be helpful to understand, especially in COVID, and how New York really tried some different chatbot approaches, as well as digital versus telephonic versus in person. How have you been, given that agile mindset, how have you been thinking through hard to reach populations? What are some of those more tactical operational approaches that you've seen some success with?
Yeah, so I think that part of it has been, one of our, initially, I think our inclusion was like, so we're really about quality versus quantity, right? So our network now is 100, which is still big. Again, you guys saw we have like 1,200 organizations in our community that provide 6,000 services. So there's also a difference between like these organizations, but each organization has a bunch of services associated with them too. So like, that's even more like there's like, with each organization is like 10 to 20 different programs of each one. So it's about like really thinking through. So even like that is like, even the adoption, like this is so common. It's like even the adoption with one organization, it's about like, are we just talking about older adults on the go transportation program, or are we talking about the refugee resettlement program? Are we talking about, so like within each organization, when you're thinking about hard to reach populations, you're also thinking about what departments are actually in the, like, who's actually using the system to collaborate in care. So like part of it is like I have a team of 5 people, and part of it's like we used to only think about bringing people onto the platform, and I think that's probably a focus of like when you think about outputs right now, it's like how many organizations can you bring on? We've totally shifted our model where I only have one staff 50% of the time brings on organizations. The rest of the staff work on adoption, data integration, and utilization. And that's about bringing organizations together to think about how they leverage it. So when we talk about hard to reach populations, I also think it's about the spread within the organization of adoption of this concept of person-centered care in general within the organization. Because when you actually think about the way we pitch it, isn't like, get on this technology platform to accept referrals. It's like, hey, are you guys ready to think about person-centered care in a more comprehensive way? Like, are you thinking about that? That's our pitch. It's not like, do you want more referrals? Like people are like, no, I have a bunch, like I already got a waiting list. You're asking me to add to my waiting list. And that's not really what I want, So it's about kind of creatively thinking about like, hey, right now, like it's basically identifying problems with our systems of care currently and thinking, is there a different way to do it? And so that's what most of my team focuses on. And that's where we think about hard to reach populations, because before it's become really difficult to address these problems. And now maybe there's a way to think about it differently by having this concept or these collaboration opportunities to think about it. And then secondly, I think like of those, like most recently, we've been thinking about how do we engage hard to reach how do we engage organizations that touch hard to reach populations, and how do we include community voice? Like how are we thinking about equity in our community voice, and so we've created mechanisms in which people can participate, community members who can participate in our infrastructure in an ongoing on an ongoing basis and share their experiences. So some of that has included like drawing what their experience has been like what does it feel like to access services? And then they draw out like,
the patient journey mapping process.
Yeah, exactly. So like being able to think about like, oh, okay, this is they fit this persona, right? Or whatever, a vignette, I guess that's like the tech terms of all these things. And then those are like the hard to reach, like these are the complicated situations that sometimes everyone's like, I don't want to deal with that. And how do we incorporate that into the way that we're thinking about our system and bring in organizations that are reflective of those communities? And it's been hard for us because like, I'm just even thinking like Planned Parenthood didn't want to join for a long time because they were afraid that like the stigma of showing that you were from Planned Parenthood could be impactful. And so like we had to go through that process of thinking about policies that would ensure that they'd feel comfortable, or, some of our local Latinx community organizations maybe were like, didn't really want to be a part of it. And like, so it's like, hey, how do we re-engage into these communities, ensure that we're supporting them? And that's been being transparent and being like, maybe things haven't worked the way before, and we want to regain those relationships and partnerships. And how do we engage refugee we have like the second or third highest refugee resettlement population in the country, and like, how do we think about those communities? What languages do we need to have translated in? Like all those kind of things is a constant. So I think that agile component of it too is just like,
yeah. I think that's Karen's point too in the chat, is that, adaptive approach is really critical. And I think this concept of ongoing working sessions that incorporate community voice, that incorporate kind of existing pathways and infrastructure, so that you collectively think about hard to reach populations versus, coming in top down and saying, we have a contract with, this MCO to reach frail older adults, go. Like, it's just, it tends to be driven by, I think, sometimes some vague contract language, or, a grant or something like that, versus really thinking about the community needs, that organizations touching multiple communities. How do we think about strategies in the context of that program diversity, the organization diversity, and the population needs? And so I think that's really interesting. Before we move on to, and I think we've been touching on this throughout, around data standardization and the minimum tech requirements to be successful in ensuring services are delivered, rendered, reached, as well as impact. Were there any other more tactical questions around outreach and coordinating outreach through the CIE or through 211's infrastructure for anyone in the audience?
Hi, this is Jillian. I'm from the NowPow team. I'm curious about, and apologies if we touched on this, like the money piece, and how talking about compensation is or is not appropriate in certain venues in terms of outreach with engaging community-based organizations. I think from my work, I've seen a variety of differing responses, sometimes super positive in terms of getting financially compensated for doing the work, and sometimes the complete opposite. I am here in the community doing this work. Like, why are you bringing this topic into, what we all actually care about, which is providing whole person care? So I'm interested in what, Karis, your experience has been like, and sort of approaches for talking about financial compensation as part of the value add for CBOs specifically.
Great question. And I can share, I think someone asked about our funding model too. So I think it's a combo of, this is complicated, right? Yes, I think CBOs need to be compensated. I think it's too assumptive to not, to say that this is not that you should adopt this without being compensated, because it does require, I think most of our experience has been the shift in workflow and person-centered care. It's there's no legislation. I think we've seen some legislation and policy. Tanya, you brought this up earlier. For example, in California, there was this policy that came out that was every hospital has to screen for homelessness now. Every patient has to be screened for homelessness. So we're oh my God, yes, this is going to be it. All the healthcare providers are going to come to us and be let's leverage the CIE. And then we look at the legislation. It's basically yeah, I can screen for it, but I just have to give people a pamphlet again. And like, it didn't really shift except for that they had to collect the data, but it didn't really shift anything in the intervention in the workflow that was like anything tangible that it felt like. There was nothing tangible in that. And so, I mean, I think that this is all, like, we were thinking like, is there financial opportunities to be able to like do this and like all these things, and like nothing came into it. So like, I don't want to be a Debbie Downer because all this is good, right? Like even ACEs screening is a new thing in California where like you can get paid to screen for ACEs, but there's no payment to like do anything with screening, right? It's like, how do we like, so it's like, how do we incentivize some of these things? And then how does it flow down to the organizations that are actually supporting the model? And so I think, yes, you have to talk CBO compensation, but I also think there needs to be some federal policy changes around the way that we fund these infrastructures, because I think it's like, and then I get frustrated sometimes with the fact it just goes to billing and like another billing code to like require CBOs to document something else. And so like that this is going to be the solution. So I think it requires some, I think that compensation has to be like the backbone organization that supports us, that should be in the community, should be funded. Because like right now we have a braided blending funding model that allows for us through contracts, through membership from our healthcare providers, as well as philanthropy, support our backbone organizations. And then in some instances, we can subcontract some dollars for like participation, like $15,000 to $20,000 to like rethink of but that it's like almost like to adopt the model, not necessarily provide the service. So I think it's a matter of transforming a lot of things. I think we do have to talk about compensation and be willing to think about the way that the way that we're addressing social needs, and maybe Karen's alluding to this too. It's like the way we've adopted social needs is like, it's not, you can't assume that we can do the same way as healthcare with social care. And because of structural racism and all these other things, like it's not like a apples to apples comparison. And I think we're moving in that direction where we're just assuming that it can be addressed by the same way as healthcare, and that we are going to pay and finance through that model. And like, this isn't just a healthcare problem. This is like a collective problem. Like we could do, healthcare is the lowest hanging fruit, but this needs to be reformed in the way that our jail systems operate and the way that our like technology like the fact that for-profit companies are making money, like there needs to be like, everyone needs to be paying into these models if we're actually thinking about changing it. So that's like a long-winded sorry, I just kind of went off on a tangent.
Well, I have two reactions to this. First is that what keeps me up at night around integrating social services and medical care is the fact that we're re-establishing a fee-for-service approach in the integration. That really bothers me, and we make some steps forward, but then exactly to your point, Karis, we set up these billing codes and reimbursement mechanisms that mirror the health services debacle to some degree. And so how do we create value-based payment approaches with CBOs that have no infrastructure, no capabilities to do that kind of reporting, to take on risk? So it's, it's chicken and egg on that a little bit until we fund infrastructure development among CBOs. Rashi, did your question get answered through the braided funding comment, or do you want to dig into that a little bit more in terms of how 211 CIE is funded?
I understand. The braided funding makes sense to me. Thank you.
So I think, the other thing that I know PHS, we've talked about in our first session, and it's come up a lot again as we think about New York City, is that interoperability and adoption of the platform, or that process to get kind of the CIE incorporated into the infrastructure that already exists. And so can you talk a little bit about that path that you took in terms of with CBOs with minimal capabilities around technology, and how that adoption of the platform, that support, what did that look like? What was that journey like?
Yeah, so I think we think about it in two ways. So it's, I guess there's like there's the opportunity to, so our data integration is not just like API, it's like you can send us an Excel document to like close out all your referrals, like through, so we like kind of allow for organizations, depending on where they're at and what applications they use, to like, to not have to go into our system to close out things or update things. Can we leverage some of their existing, like how do we make it easier for you and not make it more efficient? So I think it's on the data integration side, we like meet the organizations where they're at and figure out like, okay, we don't really like, is there a way to simplify things? Or since we integrate with are you already using some of these existing platforms that then can deduplicate? So like if we already integrate with HMAS, or we're already integrating with these federally qualified health centers, is there something that makes things easier from you on your end? Or if you want to share data with us, send it to us in any way to make that process a little bit easier. And then also, I think that as we build our platform and system, so we have a custom, I'm technology agnostic. I mean, it doesn't matter to us like which platform that you use. There's no, it's a little, but what's unique about ours is because we have control over it and can customize it, we're able to so like, for example, one of the FQHCs like didn't have a screening tool. And so we're like, all right, we'll just build a screening tool in here that you guys can use to be able to adopt it. And then it created something that was made their jobs more efficient and they could start screening for something. Or with our homeless heap dollars, figuring out a joint screener that makes it so everybody can assess the same way. Or they want to do more care coordination. They don't know what referrals they traditionally refer to. So like, could we do custom exporting of reporting for them that would allow for them to see what other needs people have? So I think it's like, it's just been like kind of a case to case basis on what makes sense. And then how does it, help them support some of their existing contracts or programs that could make it easier for them, or make their relationships more robust between providers, or those kind of things. So we just kind of really, again, focus whatever, it's just like you meet a client where they're at, you meet an organization where they're at, and kind of focus on what.
And you develop kind of what you were saying earlier, is that you have one person really focused on, the outreach to organizations, but the majority of the staff are really around that adoption and integration piece. One more question that I had, and then I'd love to take a few minutes to see if anyone has any comments or questions, which all of this, the meeting them where they are, collecting the information, standardizing it, also leads and lends itself to measuring impact. And I think the pilots that 211 has done and the data that they've put out has been really meaningfully showing that impact. Can you talk a little bit about how this effort has supported measuring and reporting impact in a way that kind of meets all the stakeholder needs? As we know, healthcare has different metrics of quality and success than CBOs, but how has this platform, how has this development kind of met all the stakeholder needs and allowed for measurement of impact?
It hasn't. It doesn't. Like, I don't think that, I can't assume that this is like a one. I think we're figuring it out, right? There's ways in which we can measure. I think what we did, we have a good job of doing is like, I mean, because we're integrated with 211, and because we had this, like, even during COVID, we were like the number to call for COVID. So we have like insane data that shows like what social needs shifted over time. Like you can see like food insecurity, like 1 in 10 callers. So like, because we're integrated within 211, like I think within healthcare, it's like we're screening, we are presumptively assuming what you need, versus at 211, you're like calling in to say like, this is what I need. This is what I'm calling about because I'm calling. So I think we're in a unique situation where we have some of that data and we can see disparities on things. Like we also were like the COVID vaccine. So we could actually see like what type of people weren't actually able to access the vaccine because of, and look at race and look at demographics and look at people who didn't have a phone number and an email. And like, we could be like, hey, county, like, did you realize this? Or like, hey, government, like the systems in place are disproportionately affecting these populations because they don't have an email or social security number or all these things. And so it allowed for innovation and response. And so, and even in the beginning of COVID, because we saw those trends, we were able to stand up resources in ways that we wouldn't have if we would have waited to look back on the data. And so I think that what's unique is it's not assumptive that we are solving for all things, but it can inform a lot of things. And what it is who else is collecting individual data from people in a real, in a comprehensive, across sectors, right? So it's like a lot of times it's collected from a whole bunch of different sources. And in our infrastructure, it's kind of allowing for analysis to be done from a individual level. So I just say we have a unique data set, but we're not solving all. I mean, everyone needs to collect data. More people need to do research. Like you're collecting census data, you're collecting clinical data over here that we're not collecting. Like, I don't think it's presumptive to assume that we can collect data for all things, but I think we have a new unique data collection that I don't think anybody has done before, at least in our community, or it's just like, this is something that's not looking at a full zip code or making assumptions. It's like actual people sharing their stories, and we're collecting it from a lot of different ways they're accessing services and can kind of put that story together.
Okay. Any other comments, questions for the next 5 minutes before we kind of summarize this very rich discussion?
I was just going to chime in, sorry, Jillian, again from the Now Proud team, that I think, Kara, something that you mentioned early on, which I think also resonates with the data piece of the conversation, is, you know, when folks or organizations assume that technology is going to solve all, and then also make the assumption that, well, because there's technology in place, we're going to get data and it'll be there and we'll figure it out later, without necessarily a plan from day one in terms of what data for which parties and what is the source of which data element and which technology tool has this versus what do we have to go out and ask community members about. So I see that as, you know, when we think about scale and we think about equity, that's a really important piece of the picture, from pre-implementation, during implementation, post go live of an intervention, to really be talking with all parties about that. Because I think sometimes people get frustrated when they're maybe a year into, you know, an intervention, and then they realize that they don't have all of the right pieces in place to be able to measure success, and really maybe have never defined what success looks like. And like you mentioned, oftentimes it's not just did we save dollars, it's did we make people's lives better, and how are we defining that? So I certainly, in not in all conversations, but in some, see a need for, you know, someone to always be bringing up that sort of evaluation piece all throughout the life cycle, to ensure that all parties feel good about the work that they're doing, and are recognized for even, you know, some of those. You had one slide that had some of the sort of outputs and outcomes, and celebrating successes all along the way, even if that success isn't, again, dollars saved, because oftentimes it might not get there, and that's okay.
I think, Jillian, just building on that point, one thing I've heard a lot from payers is, you know, and CBOs really, is when you do facilitate that integration, that joint definition of success. Now, Karis, your point is really great. Like, what hospitals are going to need to report to their boards is not going to be solved by the CIE, and not all the data is going to be there. But what is that joint definition of success? Because what's been really hard for CBOs to secure longer term funding has been their impact statement and their ability to communicate their success in healthcare, you know, friendly terms. And so I think that, you know, Jillian's point is really well taken, is that discussion needs to happen throughout, so that everyone, and it completely ties back to the power dynamics, right? So who gets to decide what's the measure of success, and who's not thinking about it because they're so busy really thinking about the individual needs, is part of that power dynamic that sneaks up on you in a year, and you can't tell the story of the impact you've had, and therefore you can't secure the funding that you need to keep a pilot going or make it sustainable. So I think it's a really important aspect of network development and stakeholder engagement that has to be part of the initial conversation. Any other comments or observations?
I had just one more, Karis. You had mentioned early on about some of your challenges in just other areas, right? So here's San Diego, and then there's the entire rest of California. So I'm just curious because, Sarah Redding in her presentation talked about, how they are building some sort of communities and networks in New York. And I'm just curious, some of the challenges you've had. I've read some papers, like the Nat Health did something evaluating what was going on in LA and some of the challenges there. So I'd love to just hear a little bit about that.
Are you talking about like multiple technology systems?
Yeah, multiple technology systems, multiple networks. What happens when somebody moves out of San Diego to LA or to, some other area of California? Are they tracked? Like what happens?
Mm-hmm. So there's multiple different, so they could be tracked. I think that there's some standards around like, how do we share? I think what you're alluding to is like multiple technology systems. There's like even a lack of definition about how do you, like, what's a profile in because like, I feel like healthcare has a very standard way of like creating a client, like how do you do master patient matching, like all that stuff. There's like there's an infrastructure for it. And in CBOs, it's like some people collect, some people check your ID, some people don't, some people collect social, some people don't. So like there's even like a master patient management index that's like, even in for social services, I don't know if it's fully like what's the right person to be able to map them across the network. So in San Diego, technically we could, like if someone else wanted to accept our person across a different network, it's not like our infrastructure wouldn't integrate that. I think that our focus has been more on creating standards or opportunities to connect via connection versus assuming one technology can solve it. And so it's less about the technology, I guess, from an infrastructure, but if we can create some sort of standards to communicate across different systems. So regardless of what technology platform you're applying, you can still, a person could connect into those different systems and there wouldn't require a duplication. And I think that technology is assuming like single sign-on is solving for some of that. Like you can single sign on into these different technology systems, but then it requires you to duplicate all the documentation. To your point, Lisa, it wouldn't work then. It's like you log into this system to repeat or reconsent in this individual into a new platform, into a new system. And so I think it's a matter, and I think that that's been interesting to like, even, like there's a million things like consent on that. What does that mean? We have our own consent that was bred within our, like leveraged within our community, and it's married, it's joint within existing consents in other organizations, which I don't know if that's a model that's being adopted, and then how does that consent then translate across different systems? I'm not sure. And like, does that mean that, or what does a client want? Does a client want their information now that I moved to LA? Does my housing history still follow me over here when I am in a completely new housing situation? Is that necessary? I think it might be different maybe with their, so I think that there's some components to that I would have to think through. We haven't shared across systems, and I actually would love to ask clients about what they think. Like if you move to a new state, would you want your social record to be followed, or would you want to have it be sort of new? And I feel like healthcare is a little bit different, right? Because that's like ingrained, but social is like this whole new data. So making assumptions around that, I think, is sometimes it's a catch myself even, like, oh yeah, let's share it. And then I'm like, wait a second, what about the person-centered model would be helpful in that situation? Would it be helpful or would it be not helpful? And I watched The Social Dilemma, so I'm like extra freaked out. And I was like, am I part of the problem? Like, existential crisis. So I also feel like, the way we've been doing it doesn't mean we have to do it the same way. And so how do we start thinking like through these types of situations that like, what's the best from a person-centered model? And I'm not saying we've solved it. That's just like my gut at this point in time with what's going on.
I think valid concerns, valid questioning. Ariel, do you want to pop up kind of a summary? I know you've been typing furiously on our behalf, so I really appreciate it.
I have, and yes, and let me share. I hope I captured the main points here, and I think we have enough time to kind of look through this and see what I've missed or what you think all needs to be lifted up that maybe I didn't catch in here. So if it works, I can go question by question and maybe talk about the successful approaches and challenges first, and then maybe if you want to pull any of those up into the key takeaways, Tanya, let me know.
Yeah, no, I think let's do a quick review question by question. That would be great.
Okay, great. So I think when we kind of started off with question one, we moved fairly quickly into two, so I think I have more there. But question one was, what are the key design elements to create a robust and engaged network of organizations? In terms of successful approaches, Karis, you mentioned that really developing an organic process from the start was very important. And you used a governance approach of having an advisory board plus monthly network meetings, and then also multiple work groups below that to ensure that things are functioning properly. Feel free to add anything else into as I talk if I've missed anything there. But also the approach of working county by county so that local organizations can make the decisions. And the 2-in-1 has had good relationships with the county government, which has really helped to kind of leverage relationships and trust. I'll just do challenges first and then I'll pause. And then for challenges, assuming that social needs can be solved by technology, I think that was a theme that kind of came out across each of the questions. Identifying your value proposition and who is involved in this process. It's something I think it's a challenge, but I think it's also, it sounds like it's something that's more just very important to lay out from the beginning. And then sharing across data systems in different counties and different regions across the state. I just flagged that as to what you were just mentioning based on Lisa Jacobsberg's question. I wanted to make sure we just kind of put that in there.
And the only thing I would add, Ariel, I think it came out of that first bullet, but there, I'm recalling, a conversation around power dynamics too, and that's really hard for CBOs. So it may even be hard for them to push back on the technology demands or the business needs of the MCA or payers. And I think that was a challenge we highlighted.
Yes, I can put that down. Challenges as well.
Yep.
Let's take that there if that works. And then in terms of key takeaways, kind of lifting out of the successful and challenging boxes, infrastructure and trusted relationships have really allowed for cohesion across levels of government and how to leverage a CIE at the city, county, and state levels. Key stakeholders can see what is needed from different levels. So kind of making sure that you're looking at things from the strategic view, which would include the funding and financing piece, and then from the community view to make sure that we are meeting the needs of the population and thinking about the population at hand. And then the power dynamics piece there. Anything else that anyone wants to make sure that we flag in this section?
I think we should go to the next one.
Formatting is a little bit weird. Question 2 is, what are the operational approaches for outreach, service coordination, and quality improvement that support scale, equity, and people served and demonstrated results? The approaches, I wasn't sure the acronym for, I think you mentioned the CASCA tool, Karis, if I spelled that correctly. But you developed a tool that's not required to be used by all organizations, but it really addresses the needs in a way that highlights whole person care. Strategic coordination is really important. It's kind of that design and mapping approach that's key. Quality over quantity, I thought that was really key to highlight, just the fact that you're focused now on having a dedicated staff to outreach, but everyone else is really focused on adoption and integration of the platform, integrating data and really reaching those hard to reach populations. And then for challenges, we need to be thinking more kind of holistically instead of how we've been thinking. Many screening tools are mainly binary. And then understanding that people's needs and well-being change over time, and we have to take that into consideration as these models evolve. And funding, this piece that's come out a few times, just how we're incentivizing models and supporting the CBOs. There's policies that have been put in place, but they're not really kind of working to compensate. They're not taking into account compensation for actually doing the work. And then just in terms of key takeaways there, I think that kind of the point of being agile was really important. And I kind of lifted out here, just the quality over quantity piece again. I liked that someone put in the chat, some of our biggest problems exist because we try to apply technical solutions to adaptive problems. I think that kind of summarizes things in this section well. And just this idea that we need to have systems reform, not just at an individual level. Anything else on that question that anyone wants to make sure we lift out or take out or move around?
I think that looks great to me. It captures what we discussed really well.
Perfect. Oh, actually 2 more points there was just around the braided and blended funding for the 2-in-1 model, and then patient journey mapping. And finally, around our last question on data standardization and technology requirements. Here we talked about successful approaches for 2-in-1 has been data integration. I thought that was really interesting, saying that you have a system in place that can kind of meet people where they're at, meet organizations, and kind of doing that case by case, which is really interesting. And also the fact that we are that you're doing things as kind of from a platform agnostic perspective, and working with each organization and based on kind of their project and what their needs are, and being able to do joint screenings if needed, and custom exports of reports based on the project. And I think that's really helpful and interesting for your model. And I think just challenges being the fact that you're learning, recognizing that you have to learn as you go in regards to kind of that overall, measurement and measuring impact and kind of needs across the board. So in terms of key takeaways, I think those are kind of the main things, just around the meeting organizations where they're at, plus assuming again that theme around technology not really being able to solve everything. We really need to make sure that we're thinking about that from the beginning and addressing success from multiple angles from the start.
I think that's great. And we are, I think, due back, right, Lisa?
I think we have actually.
Yeah, they were going to notify us. I think they gave us a few more minutes, Tanya, because of we went like 5 minutes late on the main presentation. So we're in good shape if anybody has any additional comments. I really liked, Karis, when you were talking about like in approaching community-based organizations, saying to them, us, we're going to give you more clients, we're going to give you more referrals is not really the approach, but like just that idea, because I come from a marketing communications background, being able to communicate in a way are you ready to come into a network with a client-centered approach? I really loved how you put that. I thought that was great. It's
yeah,
kind
and
of
I think
moving into another way of looking at things. Yeah.
And I think we were in a good spot. I think that where the market is now to where we were at the market, we didn't even have referrals as a like when we first started the CIE, it was basically like, I call it like a glorified Excel doc. Like it was like basically sharing client data. It was all about sharing client data. Like, could we at least just get these people so we knew where they were connected to already, so we had a historical record. And so we, like, when it merged, it was its own 501c3 actually, and it merged with 2-in-1, and we added referrals just in the last few years. So it was really like, so we were starting from an integration data sharing standpoint. And then it's interesting to see the shift in referrals and how much that has been the push. but that's not how, so we were at a different, like our original value proposition came from that place, not from the place. And so I think new people are starting from that place. And so I think we were lucky to have that vantage point from the beginning, which it's unique to, I think, where people are starting now. So I'm not saying it's like, I'm also saying like, we haven't figured this out. I think we've focused so much on the meso part of this too. We call it like, there's multi-level impact, like micro, like the individual, then the agencies, then the macro. And I would say 90% of the time it's been focused on how do we get agencies to connect. And then you're missing that individual and then the community if you're so focused on just connecting agencies. So we've done it, we haven't thought about it, right? And even the agencies, like we have like 7 health plans in San Diego. We have so many hospitals. We have so many FQHCs. Like not everyone's on board with this either. Like we are still figuring out how to do the value proposition. And there's like, and our state funding isn't sustainable. Not to like go down this rabbit hole of like, our Medicaid dollars are way different than some of the other transformation dollars that are in the spaces. So like Medicaid transformation in other communities, I'm like, dude, they're doing it way better than we are. We just have a lot more failures in our experience that I think people can learn from than others maybe from our many years. But otherwise it's like some communities are already like Seattle's killing it. Like they have an infrastructure that is amazing. I know Austin's thinking about some of these things. I know what Finger Lakes, like their flip system is interesting. I think they've come at it. We flew out there a few years ago and talked to them. Like, I think that like a lot of people, Colorado is thinking about it. I mean, like everyone's like thinking about it in different ways, and it should be based on what works within your community. And that's not the way that it's, I mean, and from a health plan perspective, it's thought of like, what technology can I adopt to address this across a system? And so I think that's where the power dynamics are like, wait, like, that's not how, like we can't, like, that's not the way that we have to operate and how we think about it, so it's fun.
Yeah.
In your presentation, you spoke a lot about the intentionality around community and consumer input, but then you also referenced that was sort of later to come. How recently have you all really been investing in that? Because it is a true investment and it can really throw some things on its head if you haven't had that input previously. So it's wonderful to be open and flexible, and I can imagine it's also quite challenging.
Yeah, I mean, I think our role, I think we've also having a new, like, this didn't come out of a healthcare initiative, it came out of a community initiative, which has grounded us in a way that I don't think maybe everyone's been grounded in, that I think that the community voice aspects of that have allowed for it to, because we had representation from service industries early, like direct service providers early, there was an element of community voice in that, like community health workers. I think you can kind of, I don't want to simplify community voice into like, yeah, if you have CBOs at the table, you have community voice, but there's like different levels of community voice inclusion. And I think, so there's been aspects of that like from the beginning. And now we're just going deeper, right? So we're going like deeper into like, how do we actually get community members to like be present and active in this participation and think through some of these things with us. And so yeah, so I think that there's been elements, I think it's been like, is it less about like the way that we're, to your point, like the communications of it is like where we started was more around like the like data, like how do you control your data, and like versus like thinking about your experience in accessing services and how that could shift. And like no client's gonna be like, oh yeah, CIE solved my problem, because it's not really us. It's really like we are just creating a system to better give people information to provide trauma-informed care. So it's also the narrative like we are not solving the problem. These CBOs are solving the problems, but we're creating an infrastructure in which you can make better decisions and more informed care around that and support this. So I also think it's like, I feel like we've also been in a weird place of like, how do we engage people to be like, what is the CIE? It's like, it's not about us, it's about the services that you're accessing, what that experience is like. So it's also about like, how do you communicate things in a way, or how's your data owned and controlled? Like, how would you feel about having your data shared across these different things, or what data should be shared to these type of providers? Or, when you revoke, like, would you want your data used to help inform better practices across the community and those kind of conversations. So yeah, so it's been an evolution, and I think that I think, again, like you were saying, Christine, it's like how are we intentional, and like not saying that we've figured it out, but like how do we keep rooting it back into that and be thoughtful through our experiences. And I think it goes back to the strategic / the person-centered. So you have to be like business oriented, and you have to be inclusive, and like how do you create spaces where everyone's voice is heard, but you don't let it get sidetracked to your strategic. So it's like, let's create those spaces, but then let's make decisions around like, you know, how do we get these things moving forward? And so it's a elegant system, but when you have all these players at the table, you can figure it out, you know, and when you have a backbone organization that's leading it to be inclusive and to be thinking about these policies and making some of those decisions, I think we are able to set up things in ways that allow we get the information and make decisions. Is this what you mean? Take it back. Is this what you mean? You know, it's just creating a framework to be able to get engagement in ways that before people were just making decisions the whole time. We just create an infrastructure to be able to check in on those assumptions, which I make assumptions all the time. I'm assuming this is going to work. Does this really work? No, it's not. Let's tweak it. So it's like this thing of like, that's what I tell my team. I'm like, C's get degrees. Like, let's just get a C on this, and then we'll figure it out. Let's just like push this out, and then if people give it back, let's check it in. So never try to make things perfect. Let's just like test our assumptions a lot.